Hello, and welcome to the ASCO Daily News Podcast. I'm Dr. Neeraj Agarwal, your guest host of the ASCO Daily News Podcast today. I'm a professor of medicine and medical oncology at the Huntsman Cancer Institute, University of Utah, and editor-in-chief of the ASCO Daily News. I'm delighted to be joined by Dr. Jeanny Aragon-Ching, a GU medical oncologist and the clinical program director of GU Cancers at the Inova Cancer Institute in Virginia. Today, we will be discussing some high-impact abstracts in GU oncology that were presented at the 2026 ASCO Annual Meeting. Our full disclosures are available in the transcript of this episode. So, Jeanny, it's great to have you on the podcast today.
Thank you so much, Neeraj. It's a pleasure to be here. So, ASCO 2026 featured some fascinating advances across GU cancers, and I'm very excited to dive into them with you today. So, let's begin with the prostate abstracts. So, first of all, Neeraj, congratulations on presenting the impressive results from the phase 3 TALAPRO-3 trial, a simultaneous publication in the New England Journal of Medicine. So, can you give our listeners an overview of the TALAPRO-3 trial, its rationale, design, key findings that were presented?
Of course. Thank you, Jeanny. TALAPRO-3 is a global phase 3 trial designed to address an important unmet need in metastatic castration-sensitive prostate cancer or metastatic androgen pathway modulation-sensitive prostate cancer per the new PCWG4 criteria. So we know that patients whose tumors harbor homologous recombination repair gene alterations or HRR gene alterations often have more aggressive disease biology and poorer outcomes. At the same time, PARP inhibitors have demonstrated substantial efficacy in the metastatic castration-resistant or androgen pathway modulation-resistant prostate cancer. So the rationale behind TALAPRO-3 trial was to determine whether introducing a PARP inhibitor earlier in the disease course could further improve outcomes for our patients. The trial enrolled 599 patients with HRR gene-altered MCSPC or MAPMS who were receiving androgen deprivation therapy, and patients were randomized to receive either ADT plus enzalutamide plus placebo versus ADT plus enzalutamide plus talazoparib. The primary endpoint was radiographic progression-free survival, with several important secondary endpoints, including overall survival, time to PSA progression, and time to subsequent therapy and quality of life. The results were quite encouraging. TALAPRO-3 met its primary endpoint, demonstrating a statistically significant and a clinically meaningful improvement in radiographic progression-free survival. The combination of talazoparib and enzalutamide reduced the risk of radiographic progression or death by about 52% compared with enzalutamide alone with a hazard ratio of 0.48. Median rPFS was not reached in the combination arm versus 45.8 months in the control arm with enzalutamide. Importantly, the benefit was observed across pre-specified subgroups, including patients with BRCA alterations, as well as those without BRCA alterations but who had other HRR gene mutations, more specifically in ATM mutation cohorts and CDK12 mutation positive patients. We also observed improvements in key secondary endpoints such as time to PSA progression and time to subsequent systemic therapy with a hazard ratio of approximately 0.5. Although overall survival data remain immature, the trend currently favors the combination arm. Regarding the patient-reported outcomes, there were no clinically meaningful differences observed overall in the patient-reported outcomes between the talazoparib arm and the control arm, except appetite loss. As expected, with PARP inhibition, anemia was the most notable adverse event and represents an important consideration when managing patients in clinical practice. Overall, TALAPRO-3 trial provides strong evidence that a biomarker-selected approach using talazoparib plus enzalutamide can significantly improve outcomes in patients with HRR gene-altered MAPMS or MHSPC, and further underscores the importance of early genomic testing in this disease.
Thanks again for that wonderful summary, Neeraj. Now, since the incidence of grade 3 anemia was relatively high, can you tell us how did you manage the anemia?
It's a great question. So, regarding anemia, I'd like to highlight that at baseline, before starting protocol treatment, about 43% of patients already had grade 1 or 2 anemia. And then grade 3, 4 anemia tends to occur early on, with a median time to onset of about 3 months. And the incidence of grade 3, 4 anemia declines after week 13 of treatment. So I'd like to highlight that protocol mandated grade 3, 4 anemia to resolve within 8 weeks to allow continuation of treatment with talazoparib. And this likely contributed to relatively high use of packed red cell transfusion in these patients, which occurred in about 40% of patients, to fix the grade 3, 4 anemia within 8 weeks to allow patients to continue talazoparib treatment. In addition, protocol also mandated dose reduction of talazoparib for grade 3, 4 anemia. Now, this transfusion and dose reduction happened early on, and dose reduction likely allowed patients to continue treatment with talazoparib, as evidenced by similar duration of talazoparib treatment of approximately 3 years in patients who developed grade 3, 4 anemia versus who did not. So key is to monitor the patients early on, every month with CBC, and in those patients who are on track to develop grade 3, 4 anemia, we can preemptively reduce the dose of talazoparib because it's not going to be a protocol mandated waiting here. It's a real world scenario. And in that case, we can allow patients who are on track to develop grade 3, 4 anemia to have a timely dose reduction and receive talazoparib for appropriate duration. I like to also point out that only 5% of patients had to permanently discontinue talazoparib because of anemia. So timely management of anemia is the key.
Thanks so much, Neeraj, for clarifying that side effect as well as how to manage it.
Now, there is another important trial in prostate cancer, ARACOG trial. Can you tell us more about the ARACOG trial presented by Dr. Morgans?
Absolutely. So, this study was presented by, as you mentioned, Dr. Alicia Morgans from the Dana-Farber, and the title was Cognitive Effects of Darolutamide versus Enzalutamide, Results of the ARACOG Randomized Clinical Trial from the Alliance for Clinical Trials in Oncology. So, this was a prospective phase 2 trial that looked at the differences between the two major ARPI drugs or androgen receptor pathway inhibitor drugs in use, currently enzalutamide versus darolutamide, in terms really of quality of life and cognitive effects. So ARCOG compared both objective and patient-reported cognitive outcome measures between patients with metastatic HSPC and, as you mentioned earlier, Neeraj, is now known as metastatic APMN. These are the new terms from the Working Group 4, or metastatic CRPC or APMR, or non-metastatic CRPC, treated with either enza or darolutamide. They use a research-grade computer-based validated platform to measure different cognitive domains. So this spans memory recall, spatial working memory, short-term visual memory, working memory, and rapid visual processing and executive function. So what they did was they tested patients at baseline, 12 weeks, 24 weeks, and 48 weeks. And in addition, crossover was actually allowed at 12 weeks and 24 weeks for pre-specified significant decline in either patient-reported outcomes or CNS-associated events. So in essence, patients can cross over to the other drug. So the findings showed that of 111 patients, 55 received darolutamide and 56 received enzalutamide, of whom the median cognitive change in the what they call MCCD, so maximally changed cognitive domain, shows that between the baseline and 24 weeks was negative 15.8% for darolutamide and minus 36.1% for enzalutamide patients. This was statistically significant, hence meeting the primary endpoint. So, therefore, the conclusion from the authors is that the primary endpoint of differential cognitive effects was met. So, enzalutamide showed greater cognitive declines in scores compared to darolutamide at the 24-week mark. Now, the results were not really completely unexpected because we have known since a long time ago that darolutamide crosses the blood brain barrier a little less. Hence, the study actually met its pre specified endpoints. However, I think it is important to note that the study did not evaluate the usual efficacy endpoints of primary endpoint of disease-free survival. Hence, the need to still be very cautious regarding interpretation. Now, in addition, we also know that duration of treatment for de novo upfront metastatic APMN patients can really extend to several years. Hence, the importance to understand the impact of these differences and how it evolves over a longer treatment time duration. And it's also important to remember that darolutamide was actually provided at no cost to trial participants, whereas enzalutamide had to be obtained through standard of care, so through insurance. And the extent to which these actually influence the differences and reported treatment experience by the patients and outcomes remains unclear.
That's a great summary of the ARACOG trial, Jeannie. And you provided a very pertinent context for the results. So thank you for doing it.
Neeraj, moving on to another late breaking abstract, it was very exciting to see prostate cancer represented in the plenary session this year. So I'm referring to the PROTEUS study, or perioperative neoadjuvant and adjuvant apalutamide plus androgen deprivation therapy versus placebo plus ADT with radical prostatectomy in high risk localized or locally advanced prostate cancer. So, final analysis of the PROTEUS phase 3 study led by Dr. Mary Ellen Taplin from the Dana-Farber. So, can you tell us a little bit more about this trial?
Absolutely. Proteus was one of the most important prostate cancer trials presented at the ASCO Annual Meeting this year and was featured in the plenary session. So, this was a global phase 3 trial that enrolled more than 2,000 patients, so 2,100 patients approximately, with high risk localized or locally advanced prostate cancer who were candidates for radical prostatectomy. Patients were randomized to receive 6 cycles of neoadjuvant apalutamide plus ADT or placebo plus ADT before surgery, followed by an additional 6 cycles of adjuvant therapy after surgery. So, approximately 6 months of ADT plus minus apalutamide before and 6 months of ADT plus minus apalutamide after surgery. So, the study had two dual primary endpoints: pathologic complete response or minimal residual disease rates at radical prostatectomy, and metastasis-free survival assessed by either conventional imaging or PSMA PET scans. Importantly, both primary endpoints were met. The PCR, or pathologic complete response MRD endpoint, demonstrated a substantial benefit with a rate of 8.9% in apalutamide arm versus 1% in the control arm, representing an approximately 9-fold improvement following 6 months of neoadjuvant ADT plus apalutamide prior to surgery. The second primary endpoint, metastasis-free survival by conventional imaging or PSMA PET imaging, was also achieved. The hazard ratio was 0.80 in favor of the apalutamide plus ADT arm, translating into 20% reduction in risk of metastasis or death with 1 year of perioperative apalutamide-based therapy. A key secondary endpoint, event-free survival, defined as time to first PSA progression or local or regional recurrence, distant metastasis, or death from any cause, also favored the apalutamide arm. The hazard ratio was 0.71, corresponding to a 29% reduction in risk of oncologic events or death with apalutamide. So, to summarize, the addition of apalutamide to 1 year of perioperative ADT resulted in a 9-fold increase in the PCR MRD rates, a 20% reduction in the risk of metastasis or death, a 29% reduction in risk of recurrence or death, and a 3-year prolongation in time to next treatment from 41.5 months to 74.2 months. So, PROTEUS provides evidence that perioperative systemic intensification can improve both pathologic outcomes and clinically meaningful long-term endpoints in high-risk localized prostate cancer. Given the magnitude of benefit, many are viewing these results as potentially practice-changing for appropriately selected patients undergoing radical prostatectomy.
Thank you for that great overview and summary, Neeraj, of this large phase 3 trial. So, how do you think you would put this data in perspective for those patients who are contemplating radiation therapy?
I will make it easy. I think the first decision is whether the patients prefer radiation therapy or surgery for their high risk localized or locally advanced prostate cancer. And if they decide to choose surgery, the findings of PROTEUS trial become relevant for them. So in those patients who are undergoing surgery, perioperative ADT plus apalutamide is likely a solid option. So there is another abstract that looked at crossover between docetaxel and lutetium in the MCRPC setting. Jeanny, can you tell us more about this, please?
Yeah, sure, Neeraj. So this study is titled Canadian Cancer Trials Group, so the CCTG study. They call it otherwise PLUTO, which is the results of the crossover treatment from a randomized trial using lutetium, PSMA, I'll just call it lutetium for short, versus docetaxel in patients with metastatic CRPC. So this represents one of the more practical questions of outcomes based on crossover treatment and sequencing between docetaxel versus lutetium. As a reminder, the PLUTO trial included a total of 199 patients with metastatic CRPC who failed prior ARPI, so androgen receptor pathway inhibition drug, and were initially randomized in a 1:1 fashion to receive either lutetium or docetaxel therapy first, with crossover permitted at radiographic progression. Now, it's important to note that the authors only presented the outcomes during this ASCO meeting regarding patients who crossed over, showing similar overall survival between the groups. However, it's also important to remember that substantially fewer patients were able to cross over from lutetium to therapy to docetaxel. So that was only 42 patients compared to those who started with docetaxel and crossed over to lutetium. So there were more patients, 62 patients. So this imbalance is an important contextual consideration. At the primary analysis, there was really no significant difference in the primary endpoint of first-line radiographic PFS with a hazard ratio of 1.01, and this was actually already presented previously at ESMO last year. Overall survival was in favor of patients who randomized to receive docetaxel first with a hazard ratio of 1.64. And again, as a reminder, there were 159 patients who had a radiographic PFS event on first-line therapy. And of all these 130 patients who were alive, 104 patients were able to cross over and receive the treatment of the other arm. As I mentioned earlier, more patients on the docetaxel arm were able to cross over to lutetium, 62 patients, and only 42 patients from the lutetium to the docetaxel arm. There were no clinically relevant differences in the baseline characteristics of these patients who had crossover therapy between the arms. OS was worse for patients who were not able to receive the crossover treatment compared to those who were able to cross over. And for these 104 patients who received both lines of therapy, there were no differences in efficacy outcomes for second-line RPFS, RPFS2, OS, or second-line OS. Notably, PSA decline of more than 50% was higher in those who were able to cross over from docetaxel to lutetium. This was about 69% versus those who got docetaxel after lutetium, only 40%. And in summary, the small phase 2 trial showed us that there was no major difference between the OS between docetaxel or lutetium. More patients were able to cross over to lutetium, although the ability to cross over was slightly more likely if you started with docetaxel chemo rather than lutetium first. Now, we do need to be cautious regarding over-interpreting this small phase 2 trial, especially given the imbalance between both arms. But perhaps the more practical message is that patients might be able to benefit from either drug, regardless of the sequence, especially if one is not able to easily access or have availability of lutetium.
Thank you, Jeannie. So, patients who were able to cross over in this trial from lutetium to docetaxel or docetaxel to lutetium seems to have similar survival. And basically, these results, as you said, with all the caveats of being a small phase 2 trial, basically tells us that both are reasonable options for our patients, and patient selection is going to be the key when we are selecting one of these two options in our clinics.
So thanks, Neeraj. Moving on from these potentially practice-changing data in prostate cancer, let's now shift gears and talk about bladder cancer studies. So Neeraj, what caught your attention in this space at ASCO 2026?
So, Jeannie, let's talk about the EV302 3.5-year follow-up and response analysis data presented by Dr. Tom Pauls. As you know, this phase 3 trial randomized 886 patients with previously untreated, locally advanced, or metastatic urothelial carcinoma to enfortumab vedotin or EV plus pembrolizumab versus platinum-based therapy. With a median follow-up of 3.5 years, the results remain consistent. Median overall survival was 33.6 months with EV plus pembro, compared with 15.9 months with chemotherapy, corresponding to a 47% reduction in risk of death with a hazard ratio of 0.53, favoring EV plus pembro. At 42 months, 44% of patients receiving EV plus pembro were still alive, compared with only 24.6% in the chemotherapy arm. The objective response rate was 67.5%, compared with 44.2% for chemotherapy. More importantly, the complete response rate was 30.4 months, more than double the 14.5% observed with chemotherapy. What really caught my attention, however, was the detailed analysis of patients who achieved complete response. Among patients treated with EV plus pembro who ultimately achieved a complete response, only about 1/3 achieved a complete response immediately. Nearly 2/3 of these patients who eventually have complete response actually first achieved a partial response and then later converted to a complete response with continued treatment. And this has major implications for clinical practice. In other words, many patients continue to deepen their response after the first scan. At 42 months, overall survival exceeded 83% among patients with complete response and remained above 82% even in those who initially had only a partial response before converting to a complete response. So the achievement of complete response either immediately or later is a fantastic news for our patients. Historically, metastatic urothelial carcinoma has been associated with poor long-term outcomes. Yet, in EV302, roughly 1/3 of patients achieved a complete response, and more than 80% of these patients were still alive after 3.5 years.
Thanks for that great update, Neeraj, on EV302. So, EVP has definitely rapidly changed the treatment landscape for our patients, delivering unprecedented survival benefits for patients with advanced metastatic urothelial carcinoma. Was there any updates on the toxicity profile?
The toxicity profile remained consistent with what we have previously seen with EV pembro, with treatment-related adverse events remain manageable and no evidence of unexpected late toxicities despite prolonged treatment duration. So now let's move to the kidney cancer abstract, because the field of adjuvant immunotherapy is moving fast We already have adjuvant pembrolizumab as standard of care based on the results from the Keynote 564 trial. We saw pembrolizumab plus belzutifan data being presented in the ASCO GU, and now we are seeing the results of RAMPART trial in ASCO 2026 Annual Meeting. So, Jeannie, can you tell us more about the RAMPART trial in adjuvant kidney cancer setting?
Absolutely, Neeraj. So, this abstract's title is Durvalumab monotherapy versus active monitoring for resected primary renal cell carcinoma in RAMPART, an international phase 3 randomized controlled trial. It was actually presented by Dr. James Larkin from the Royal Marsden in London. Rampart was evaluating 1 year of immune checkpoint inhibitor therapy versus active monitoring in patients with RCC at intermediate or high risk of recurrence following nephrectomy according to the Leibovitch score or following complete resection of limited metastatic disease, what we call M1 NED. This trial has already shown that durvalumab and tremelimumab improves disease-free survival, and it randomized patients in a 3:2:2 ratio between Arm A, which they considered active monitoring, and Arm B was 1 year, 13 cycles of durvalumab monotherapy, so only durvalumab, or Arm C, which was 1 year, 13 cycles of Durva and Tremi for a total of 790 patients. So recall that this trial was actually preliminarily presented last year at ESMO, showing improvement in the Durva-Tremi combination arm, which improved the 3 year disease free survival of the combination at 81% for the Durva-Tremi versus 73% in the active monitoring arm, and the hazard ratio there was 0.65. So, particularly, this ASCO presentation was looking at the comparison between durvalumab monotherapy compared to active monitoring. So, the results of that showed that the disease free survival at 3 years was 78% with durva monotherapy arm compared to 72% with the active monitoring arm. And while this was numerically associated with 26% relative reduction in the hazard of disease recurrence or death, with a hazard ratio of 0.74, this did not meet conventional statistical significance. So, hence, it was actually considered negative in terms of the Durva monotherapy compared to active monitoring. There was no evidence of a treatment by subgroup interaction that was observed. Therefore, the conclusion was durvalumab alone did not improve disease free survival over active monitoring, although the previously reported combination of durva-tremi actually did. So it is important to note that this combination right now, as we speak, is not FDA approved yet. And the trial initially planned enrollment for actually 1,750 patients, but was ultimately pared down to only 790 patients because of COVID and because of Keynote 564 adjuvant pembrolizumab results. So it was somewhat underpowered.
So, just to summarize, Jeannie, Durva-Tremi has shown improved DFS or disease-free survival in adjuvant renal cell carcinoma setting compared to active monitoring. But this ASCO update did not show Durva monotherapy to have improved DFS associated compared to the active monitoring arm.
Correct.
And of course, the combination is not yet approved. So we look forward to further news on this one. So that wraps up our GU abstracts from ASCO 2026 Annual Meeting. We have covered a broad spectrum of innovations with strong clinical relevance. Thank you for joining me today and sharing your insights.
Thank you so much, Neeraj.
And thank you to our listeners for joining us. You will find links to the abstracts discussed today in the transcript of this episode. If you find these conversations valuable, please take a moment to rate, review, and subscribe to the ASCO Daily News Podcast wherever you get your podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.